Hello, learners. This is Dr. Rohini Wine here, and today we are going to have another session of mnemonics. Okay, so isn't it fun using mnemonics and learning? So anatomy, as it is a very volatile subject. So it's always nice when you have some nice mnemonics to recall. So usually people avoid studying anatomy because it is volatile. They feel that last minute probably revision would help because anyway they are going to forget. But don't do such things. Always try to study anatomy many times so that it at least if you study some 50%, 25% will definitely stay in your heads, and another 25% definitely needs help with some mnemonic devices like the one we are going to have now. So these are something always you should some if you have any subject that is really boring, you should always try to make it interesting by using some other methods to study. So if you just think of going in one direction like anybody else, then it may not work. So you have to be very innovative, and even when you are studying, you should have various methods to you know think of to recall. Recalling is very important. Ultimately, why are we doing this? To recall during the exam time. If that is not happening, then what is the point in studying, right? So it's always important. You should see whether you are able to recall. So whenever you use these mnemonics, you should make sure that you are remembering the mnemonic as well. So today you may learn some new mnemonic, like I have given some 7, 8 mnemonics today. Next day morning, you try to recall those same topics with the mnemonics. So, without the mnemonics, if you try to recall and then get something wrong and then go back, instead of all that, always, whenever you are learning that particular topic, use the mnemonic. So, that way, your brain will get tuned to such a method and it will be really helpful. I have always tried this, and I've always believed that that has helped me. So try this method, mnemonics for anatomy recalls. Okay, let's see. There's anybody who has messaged or trying to. Oh, nice. Okay, there we have. So here are some of the credential educational, credentials that I have even in my profile. You please visit my profile. It is Dr. Rohini Wayan. Okay, you can also see that there are links to the profile, and there is link to the Telegram group that is next to the YouTube, whatever you're watching right now. Next to that, there is a small drop down. If you click on the drop down, it will take you to my profile. And you can also see that this is my user ID, ROHAQUA. So Unacademy, if you just type in Roaqua, it should take you to my profile as well. And also, you will see my additional qualifications. What is MT? MT is medical transcription, because I was working for a hospital in USA, and all the doctors are supposed to know to read those, uh, the summaries, discharge summary, then various summaries that we have. And also, I have this medical, hospital administration MBA. And there is this PhD that I have recently achieved, that is from the Savita University. This is at Chennai. So I'm very passionate learner, and I have always believed that learning never ends. So it never ends for educators, not for the students. So always keep yourself occupied with something or the other. That is really a way of keeping your brain active. And I have also done this course, embryologist course in IVF and ICSI, which is called the ART course. assisted reproductive technique. So these are some of the, things. If I don't have one kind of a job, I'm doing something else, but I'm not resting. So this is the attitude that I have. And with so many years of experience, I also do a little bit of counseling the students. And here is my referral code, ROHINI. Use the referral code when you feel that you need the subscription and you want to get discount of 10%. Do use the code. And also the free products like the special classes, quizzes, tests, everything you can have access to with the code only. Okay, so these are some of the dedications that you can see from the students. And look at the dedications. There is red hat, blue hat, orange. All these are some nice, encouraging hats that are given to the students when they achieve certain minutes of watch time. So here there is 1,000 minutes. The person has a blue hat, and here brown hat is for 10K minutes and orange is for 100 minutes, so on. And when they get these hats, they dedicate it to their favorite educators or from whom they have learned something nice. Okay, so that is one thing. And I do have some dedications. This is what is displayed. So this is my way of thanking them. And also I have a bunch of followers, and that is my profile. And the followers goes on increasing day by day. By now it must have crossed 300, and all that you can check out in my profile. And you can also see that there are some nice new things that's happening now that the exam dates are going to be announced or almost announced. And we don't know whether there is going to be any change, but can definitely look at the exam happening in next 2 months. Okay, so we have some nice thing that has been launched. In case you feel that more than 3 months subscription is not going to of any help to you because you are going to face the exam in 2 months, here we have the new thing that's launched, 2 month subscription. And the price is also slashed for an introductory offer of 6750 only. So all this is nicely explained in my YT shorts. Just go have a look at the YT short as well on this weekend and see what's new at our Unacademy platform. And you can start preparing and let's crack it. And there is this to support your NEET PG preparation. This is the new thing. And you can also see that all these things are for your benefit. So much is done to encourage the students from reaching their goal, right? Okay, there is plus subscription also that gives you classes, structured courses, unlimited access, and so on. And there is also iconic subscription, which gives you not just Unacademy, but also the best of Prep Ladder with all the rapid revisions, video lectures, and live classes and quizzes. And there is limited time offer. 36 months is going to be just 58,500, and there is a big slash in the price of 10%. And you can also see 24 months is going to be just 49,500, and similarly 18 is 45, 12 is now 4,500. There is a big slash in the price. Okay, you all can get this if you are the first 500 of them. And then you can also, think of using the code. Don't forget the code ever. That is my name itself, ROHINI. And there is this INI-CET and NEET PG boost preparation, and that is 3+1. And you also have 12+2. So this was there something that has been always there. But now what is new is the 2 months subscription. So 2 months, 3+1, and also you have 12+2. So look at all these options and decide. There is something nice for the ones who are still undergraduates, like 4-year subscription. If they are in undergraduation and they want to have a firm foundation towards their NEET PG preparation, you can do all at one place. And here you have plus subscription for 60,000 and the iconic is for 75. You can avail all this, use the code, and also get the 10% discount. And there is a new feature, if you have seen, this is seen in the plus subscriptions. Okay, so plus classes, if you have been attending, you will see this new feature called the raise a hand, where the student can raise the hand and the educator can interact with the learner just like the offline class. It could be so interesting when someone asks questions and it gets clarified then and there. So isn't that interesting? Okay, so you also have integrated clinical batch part B. All this is running parallelly. So all this is very interesting with the top phase educators, as you can see, and it is going to be very innovative and different form of learning. And target next 2022 and professional year 2 batch, all this is starting from 14th July. Okay. So where you have all these live interactive classes with the top learners, top educators, and also the PDF notes are given, revision classes are conducted, and also recorded sessions are available in case you happen to miss. So doubt clearing and also all the difficult concepts are explained in a very different manner. And you can also see Focus FMGE batch where 14th of July it started. And here also you have integrated approach, recorded sessions, PDF notes, everything is available. And you can also see that there is iconic and plus subscriptions, 48 months of subscription. You know, you have to just pay 1,125 per month and 36, 24, like that, so on, all these months. But you need to have minimum of 6 months subscription, which is going to be, making you eligible for the no cost EMI. Okay, so that is 1125 for plus subscription, and iconic will attract little more, 1406 per month. So don't forget the code here as well. It is ROHINI. Okay, that's my name, Dr. Rohini Wine. And for all those who have been patiently watching, like I have about 7 to 10 students who have been patiently watching, I would like to thank you all for watching patiently and waiting for the class to begin. And this is the referral code again. And don't forget to follow me on my profile. And you know the profile picture I showed you how to go to the profile, and there is a link on this video itself. You can make out on the side there is the drop down, click on that, follow the link. Okay, here we have the first one. What is fallot's tetralogy? Now, fallot's tetralogy, let's see if there is anyone who has any message. Okay, what is fallot's tetralogy? Now, tetralogy of fallot, that is also called the congenital. It's also the congenital anomaly, right? The pediatric, pediatrics, you must have studied what is fallot's tetralogy. Here, there are 4 different things that, you have to remove. One is PROV, proof. You can remember it as proof. So first one is pulmonary infundibular stenosis. That is most important determinant factor for prognosis. That is pulmonary stenosis. Okay. So Fallot's tetralogy, you can also abbreviate this as TOF. Tetralogy of fallot. And it is a cardiac anomaly. That is the first thing you can, that's the first thing to note down. And then you can also remember that there are 4 related, anomalies or the defects. And you can also remember there is boot-shaped heart in this, which you can see. Why is this one? That is because of the right ventricular hypertrophy. right ventricular hypertrophy will cause the boot-shaped heart, and also you can see the diaphragm is pushed downwards, and there is also overriding aorta. All this you can see in the picture, and these are some of the first one. This is the second one. This is the third one, and fourth one, ventricular septal defect. Okay, so this is what happens. These are the things that you can identify. You can see this picture also. You can identify. This is the pulmonary. Okay, you can see there is narrowing of the pulmonary trunk. So there is stenosis. You can see that here, and narrowing of the pulmonary valve also you can make out, and that is the first one. And there is the second one, right ventricular hypertrophy. This is the second one. And there is third one, overriding aorta. You can see this one. This is the overriding aorta. This is the third one. And the fourth part is the VSD, ventricular septal defect. This is the fourth one. So this is fallot's tetralogy. All right. So you can remember it with the mnemonic PROV. So you can remember the E also, that is ventricular septal defect. Next one. There are little more explanations on the same. Let's go through those things. What, why, and how is the question that we always get in our minds. Now, fallot's tetralogy, you know that it is the most common cyanotic congenital heart disease. Okay, if you go for the statistics, now you know that it is males are the ones who are the more at risk, and there is first degree effect of CHD, that is cyanotic heart disease, and the risk factors are tetrogens and genetic predisposed conditions. Okay, now there are three categories you can see. The first category is very mild, where the baby could be like asymptomatic until the age of 1 to 3 years, and moderate to severe, where there is cyanosis and there could be respiratory distress at the age of from the newborn age up to a week 1. And there could be extreme cases where the cyanosis is present, and also the respiratory distress is seen as soon as the baby is born within few hours. So that is three categories you can see. And then why does this happen? Okay, so now mild diseases, that is left ventricular pressure is more than the right ventricular pressure. That is one thing. And there is acyanotic, that is another reason in case of mild disease. In case of severe ones, you can see that there is pulmonary stenosis. Okay, that is one thing where the right ventricular, that is right ventricular pressure is more compared to the left ventricular pressure. And there is, of course, cyanosis seen, but in case of mild, it may not be seen. The baby may still look pink. And there is investigations that they can do to, make this even more, kind of stress upon. There is ECG done, there is boot-shaped heart noted with the X-ray, and there is echo that is done, that is gold standard echo, and other things, examinations like the cardiac MRI is also done. And how do you manage this? It could be managed with medications and the surgery. As you know, there is repair surgery between the 4 to 5 months, that is up to 4 years, it could be waited. And following the surgery, 80% of the survival rate to adulthood is present. All right. So that is fallot's tetralogy. Next one, let's see what is this one. Anybody else who has any questions, you can post it there. We will answer your questions. Since we don't have the feature of raise a hand here, I could answer your questions through the option that we have here. I could answer your questions. Okay. Next one. So here, this is ankle joint, and you can also see one more joint below that. So what is ankle joint? Ankle joint is formed by the crura and the talus. Okay, what is crura? Crura is nothing but the tibia plus fibula. Tibia and fibula is together called the crura. So it is like a bracket shaped, joint. So here you have this bracket shaped thing that is known as crura. And then you have below that talus. So this is together called talocrural joint. Talocrural joint is also called the ankle joint. Other than that, you also have one more joint below. That is called the talocalcaneal joint. Now you can see talus and below that calcaneum. Calcaneus. So talus and the calcaneus also form a joint below the ankle joint, and that is known as subtalar joint or talocalcaneal joint. Now the question is, what are the movements at the subtalar joint? Now you have this subtalar joint where two movements can happen. One is inversion, another one is eversion. This is eversion. Eversion is, facing the sole of the foot outwards. That is known as eversion. Inversion is facing the sole of the foot inwards. This is outwards. So here always eversion puts a lot of stress on the ligaments that are on the medial side. What is the name of the ligament? They're called deltoid ligament. That is called deltoid ligament or medial ankle ligament. So you please remember, when does the deltoid ligament tear or get damaged? Whenever there is excessive eversion. Excessive eversion will always result in tear of the deltoid ligament, which is also called medial ankle ligament. There is lateral ligament. Lateral ligament, whenever there is inversion, whenever there is excessive inversion, that's going to result in the tear of the lateral ligament, lateral ankle ligament. There is no other name for this. There is just lateral ankle ligament. So you please remember eversion and inversion. Who does eversion is one question. Eversion is done by only one group of muscles, and that is the lateral compartment. Lateral compartment of the leg. Lateral compartment of leg consists of only two muscles, that is peroneus longus and peroneus brevis. So remember this, peroneal muscles, two peroneal muscles will result in, bringing about this action, that is eversion. So always I can remember this lateral compartment with very nice mnemonic. I'll tell you the mnemonic, that is PLES. All of you can just note this down in somewhere. PLES. What is P for? P stands for what? Of course, L stands for lateral compartment. I would say L stands for lateral compartment. But what does P stand for? P stands for plantar flexion. So it helps in plantar flexion. And L is for lateral compartment. E is for eversion. And S is for superficial peroneal nerve. So if you ask me, how I'm short about my answers, because I always use such, methods to study, because I study it only once. If I study it once, I have to remember it. I study it in such a way that I can recall the things. So that is my method. And what's your method? So you should always have a method and stick to it. So just see what is your, method that works for you, and always try to stick to the same method. And also the timings, what time works best for you. Is it the daytime that works best for you to study, or the night times when it is very quiet? And what's the time? You sit with a coffee or you sit with something else. So you see what is the best method, what is the kind of environment that you like to be in when you're studying. So always try to get maximum gain with limited effort. Okay, so this was my method, always using some kind of mnemonic or something to relate to, so that I can never forget. I have always learned that method, and I always plan and do things. Okay, let's move to the next one. All right. So now these are the muscles that are attached to the tibia. Let's see what are the muscles. Now we are talking only about the origins, okay? We are talking only about the origins, not about the insertions. Let's see what are the origins from the tibia. So this is one of the bone on the medial side of the leg. Medial side of the leg, we have the tibia. So we have PLEAS, please engage the tall, slim girl. So I always told you, if you don't use the mnemonic when you are studying, then there is no point in, talking about mnemonics at all. So when you have to implement it, when you have learned something new, you have to implement it. So if I'm giving you the mnemonic, and if that is something you feel, okay, I can remember the things with this particular mnemonic, start implementing it from the day one. Okay, there is this, please engage the tall, slim girl. If you don't have a mnemonic, how am I going to remember all the origins? I would just mess up. I would just definitely mess up with something, right? So there is, please, you have peroneus longus, E, extensor digitorum longus. We're talking about tibia. There is, so tibialis anterior, tibialis posterior. Then we have soleus and gastrocnemius. Okay, now anterior compartment, what do we have? Anterior compartment, we have those muscles. Let's leave those muscles which are attached to the fibula. Let's leave them alone, because they are peroneal muscles, only two of them. There are three peroneal muscles, and two of them are on the fibula lateral compartment side. We'll talk about anterior compartment. Anterior compartment has one big toe, right? Big toe. What do you call that? I would call that hallucis. So we have extensor compartment. Anterior compartment is extensor compartment. So you have extensor hallucis. Then you have second one, extensor digitorum. Then you have anterior compartment, so tibialis anterior. So these are the muscles which are on the anterior compartment. All right. Then you have posterior compartment. Posterior compartment are all flexors. So what do you have? The same muscles, but you put them as flexor hallucis, flexor digitorum, and then you have tibialis posterior. Okay, but the catch is, all these are the deep muscles. All these are the deep muscles in the posterior compartment. There is also another set which form the superficial muscles. Which are they? You have heard of the calf muscle, that is gastrocnemius. Then you also have soleus. So together they form a tendon called Achilles tendon. Okay, so this is the superficial compartment. So you have deep compartment and superficial compartment. Now let's see what is the nerve supply. Anterior compartment has the deep peroneal nerve. Posterior compartment, you have the supply from the tibial nerve. And lateral compartment will have superficial, because remember I told you the PLES. So previous slide I showed you the PLES. What is PLES? P for plantar flexion, L for lateral compartment, E for the eversion, and S is for superficial peroneal nerve. So remember the nerve supply also with that mnemonic. Okay, next one. This picture should show you all those muscles. Now we are talking about the soleus. Yes, that is there. And you also have the soleal line from where it takes the origin. You can see the soleal line on the tibia. That's on the posterior compartment. This is posterior. Okay, that's what we are interested in. You can also see the popliteus muscle, and you can also see the semitendinosus, semimembranosus. Why it is together? Because these two do the same action. The popliteus, semitendinosus, semimembranosus, they all do the same action. That's why they are together. What is the action? Unlocking the knee joint. Unlocking the knee joint is done by popliteus and also accessory muscles like semitendinosus, semimembranosus, chipin. So they're together on the same side. Then you have the flexor digitorum. And similarly, you have extensor digitorum. So there is also flexor hallucis. Similarly, you have extensor hallucis. All these are the anterior and posterior muscles. Now, on the anterior side, you have tibialis anterior. See, you tibialis anterior, there is no muscle on the medial surface of tibia. The medial surface of tibia is subcutaneous. That's what you can notice here. There is nothing here, nothing in this spot. Okay, so keep all this in mind. And you can also see the extensor digitorum longus, you can see. So all these are the origins. Whatever is given in red is all origins. Okay, next one. So let's see if there is anybody who has any questions. Okay, we have Shubhadeep. Hi, Shubhadeep. I didn't see your message. I'm doing good. Thank you. Yes, now here we have next one. Colles fracture and Smith fracture. So always I would just simply remember O for outstretched. Okay. Outstretched hand. Fall on the outstretched hand is Colles fracture. I'll tell you what is Smith. Smith, you remember I. Okay. Smith is I. Just inward turned wrist. This is outstretched or outer turned, outside turned wrist. Maybe like that you can remember. Inward turned wrist. Okay, in is Smith, out is Colles. You have Colles fracture. You have to remember all D's you can remember. All the D's. So here, fracture of distal radius, D distal radius. See, look how many D's we have here. And then fall on the outstretched hand and dorsally flexed. Remember, it is dorsally flexed. Here we have dorsally flexed. And it is usually seen in the elderly because of the osteoporosis. This is one of the common fractures that you can see in elderly patients when they fall on their outstretched hand. It's always the tendency to grab something when we are falling. So most of the fractures that we see is Colles fracture. than the Smith ones. So then there is dorsal displacement of the distal radius, and dorsally it is angulated. That also you can see. And you also can see the dinner fork deformity. Okay, dinner fork deformity. So all this you can identify. Plus you can also see at the site, you can see tenderness and distal at the distal part of the forearm. So this is what you can remember. And what do you do for this? You do the closed reduction and cast. Correct? This is what you do. So remember, all the D's will give you the Colles fracture answer. Okay, isn't this interesting? Yes. Next one. So this here, it will also show you some, picture-based mnemonics. So picture-based mnemonic, image-based mnemonics also helps you to recall, right? So this is Colles fracture, where you can see this O, and here it is Smith's fracture, where you should look at the eye. So here dorsal part of the wrist joint in fall position makes a C-shaped, right? Colles shaped. And there is this dorsal part of the wrist joint in fall position makes a S shape. So instead of that, I would just remember I and O. So that is inverted C. Okay. So this is two things to help you remember. Next one. Yes, you can also remember it as reverse Colles, but if you want to have I to highlight and then remember, then you have Smith's I. Okay. So now here is nerves passing through the superior orbital fissure. How do you remember all those nerves passing through superior orbital fissure? There is leave frankly to see absolutely no insult. Okay. Leave frankly to see, or it should be freely, right? Leave freely to see absolutely no insult. So this is one mnemonic you can remember. Instead of frankly, you can also remember freely. That makes more sense. So here are the things: LFT, and then there is superior and inferior division of oculomotor. Now my question is, what does superior supply? What does inferior supply? Who can tell this? Let's see. This is a question. I wish I had the poll now so that I could ask the question. What does superior division of oculomotor supply? I would expect the answer real quick. Anyone? Superior division of oculomotor supplies. Shubhadeep, we're answering. Superior division of oculomotor. You remember just yes first. Okay, superior rectus. Write it off. And also levator palpebrae superioris. Remember this and this. Okay, that is superior division of oculomotor. Now, what is left for inferior? You have the other recti. You have inferior rectus. Then you have medial rectus. And what else is present by supplied by O? We have one more. Anybody? Anyone who knows what is the last O that is left? Inferior oblique. Okay, these are the muscles that is supplied by inferior division of the oculomotor. So SO4 that is not supplied, LR6 that is not supplied. So rest all we have covered with the superior division of oculomotor and inferior division of oculomotor. Next, let's see the abducent. It is supplying the muscle LR, and nasociliary we have trochlear, frontal and lacrimal. So all these are other structures passing through the orbital fissure. Let's look at the diagram itself to make it even more, impressive and to make it even more memorable, the picture that is picked here is very, very nice. You can also see the muscle attachments on the tendinous ring. So you can see the recti muscles around. You can also see the optic canal where the optic nerve and ophthalmic artery is there. Optic nerve and ophthalmic artery. And you can also see the three, nerves. You can see the LFT along with the superior ophthalmic vein. Okay. Similarly, you also have the inferior ophthalmic vein here. And you can see the other structures like the infraorbital nerve. And you can see this vein that is infraorbital artery. And you can also see last one that is zygomatic nerve. This is the inferior orbital fissure. This is the inferior orbital fissure. The upper portion is the superior orbital fissure, which cuts through this, which is cut by this tendinous string. And you can see the structures in the middle portion. You have four of them. That is two divisions of the oculomotor and nasociliary and abducent. Last one is the abducent. Okay, so this is what you can see in the structures passing through superior orbital fissure. Next one. Okay, we have next the abdomen and the thorax are separated by a musculotendinous structure partition that's called the diaphragm. So diaphragm has origins coming from the sternum. It's coming from the sides, that is the ribs, and it is also coming from the back side, that is the vertebral or vertebrae. So these are all the origins. And where do they come? They all converge in the center, and that is known as the tendinous or central tendon. So tendinous part, that is central tendon. And this central tendon is pierced by various structures. So those are called the major openings. Okay, they are called major openings. Like that, you also have small openings, but we do consider the major openings as more important. So we have vena cava opening at the level of T8. Okay, so at the level of T8, we have vena cava opening. Then esophagus has 10 letters. If you count them, esophagus, don't forget to put the O. So just don't start from E, then it becomes 9 letters. It is OE. So then you get the 10 letters. And there is aortic hiatus. If you go with this name, and you have 12 letters, that is at the level of T12. Or you just remember this O for esophagus. Above is vena cava, below is aorta. Okay, so this is the mnemonic for the level of diaphragmatic purchase. 8 letters, 10 letters, 12 letters. T8, T10 and T12. Okay, next one, we'll see what other structures pass along with this. Not just the major openings has got only one structure passing through it. You have many more structures tagging along. Let's see what other structures are there. So vena cava always has this phrenic nerve with it. Okay, some branches of which phrenic? You should remember vena cava is only one, so both the right and left know there is right phrenic nerve passing through this branches of right phrenic nerve. Next, we have esophageal hiatus. Esophageal hiatus, we have the anterior and posterior vagal trunks and also some esophageal arteries. Next, aortic hiatus, we have AAT. What is AAT? Aorta, azygos, thoracic duct. So aorta is descending down, azygos is ascending up, so is the thoracic duct ascending up. What about this one? Esophagus. Esophagus is descending down. The vagus is descending down. Small esophageal arteries are also descending down. And what about IVC? Inferior vena cava is descending or ascending. Inferior vena cava is ascending upwards and the phrenic branches are descending downwards. So this is things you should remember: what structures ascend, what structures descend, and what are the structures that are tagging along with the main structure. So esophagus, you remember there is a plexus that is formed by the vagus. So that's why there is vagus. And vena cava, inferior vena cava, you remember there is phrenic nerve along with that. And then you also remember the aorta has the thoracic duct together with the mnemonic AAT. Other than this, there is lesser and two lesser aperture of the right crus, and there is three lesser apertures on the left crus. So there is three on the left side, two on the right side. So altogether there are five small ones, and these are all occupied by the splanchnic nerves, then hemiazygous vein. So just remember that. And behind the diaphragm, what is there? Behind the diaphragm, you will see the sympathetic trunk running. And you'll also see some areolar tissue between the sternum and the diaphragm. So you will also see some areolar tissue with some small branches. So along with this, let's see the next mnemonic. We'll move on to the next one. What is this one? This is layers of the scrotum. Okay, layers of the scrotum. You can just remember this with the simple line, that is some, let's not use this word, Englishmen called it the testis. Okay, so S is for skin, dartos muscle, which is actually, replacing the superficial fascia in the perineum. It is replaced. Instead, we have dartos. And external spermatic fascia, cremasteric fascia, internal spermatic fascia, tunica vaginalis, and you also have tunica albuginea, and that is what is the first layer of testis. Okay, next let's see with some diagram. So you have D is replaced with dangerous. So you can put your friend's name also, right? I did not stick to such names. You can just if you have 5-6 friends, put their names and see if you can get a name. It should be made fun. And first one, skin. You can see this one. There is dartos muscle, second one. And the third one is external spermatic fascia. And that is this one. And there is cremasteric fascia. This is the fourth one. And there is internal spermatic fascia that is not shown here. And there is tunica vaginalis and albuginea. So these are the various layers you can see as the layers of the scrotum. So next, let's see what else we have. We have probably one last one. This is the nerve supply. This is the nerve supply to extraocular muscles. How many extraocular muscles we have? We have the voluntary ones and involuntary ones. Involuntary, there are three: superior tarsal, and orbitalis. And voluntary, we have 4 recti and 2 oblique. Superior oblique and inferior oblique. Superior rectus, middle rectus, inferior rectus, and lateral rectus. So these are the muscles. We can call them as extraocular muscles. Let's see. Lateral rectus is supplied by the 6th cranial nerve. This is supplied by the 6th one. Superior oblique is supplied by the 4th, that is SO4. And all others are supplied by the 3rd cranial nerve. So this, keeping this in mind, if you draw a diagram which shows the eye, this is the medial rectus, okay? And here I would just call this as elevation. This would be depression, and this would be adduction. This would be abduction. And here I would just put the superior rectus, inferior rectus, and bang opposite to inferior rectus is the inferior oblique. And here would be the superior rectus. This is, so this will be superior oblique. All right. So now coming to the functions. Now, if you have to see the action or the functions, what do you think will the superior oblique do? Superior oblique will do abduction and depression. Lateral rectus will do abduction. Inferior oblique will do elevation and abduction. You have superior rectus doing the elevation and the adduction. Then you have medial rectus doing the adduction. Then you have inferior rectus doing the adduction and the depression. Okay, so with all these movements, one question is very, very important. The superior oblique. What is the action of superior oblique? Abduction and depression. Okay, depression. If the nerve S44 trochlear is damaged, then it can result in the opposite action. Like instead of abduction, it will become adducted eye and elevated eye, adducted and elevated eye. So this is something you need to remember. When there is a lesion in the nerve supply, that action will be just the opposite action. So this is the source of all these nerves. You can see the superior oblique is supplied by the trochlear. How it is supplied by trochlear, you can see trochlear nucleus, it's coming from the pons. And you can also see the oculomotor nerve. It is also coming from the pontomedullary junction. And you can see there is this abducent coming very close to where the facial and the vestibulocochlear nerve arise. That is also coming from this junction near the pons and the medulla. And this is pontomedullary junction, and oculomotor is near the midbrain. And this is the pontomedullary junction. So abducent, facial, and vestibulocochlear, they're all at the same area. So now this is what it supplies, lateral rectus. So that's the only supply the abducent nerve gives. So when there is a damage in the abducent nerve, then the action of lateral rectus will just become the opposite. So lateral rectus does abduction. When there is a lesion, the eye will be adducted. So remember that and recall with the mnemonic always. It's always useful when you have a mnemonic to study. Okay? So with all this, I would like to thank all those who have been watching my classes, my videos, and also appreciating. I would urge all of you to go through the profile, like the profile, and also, to hit a like whenever you feel that the inputs that I give you are worth it. So please hit a like and don't forget to follow me on my profile. And that is really motivating, and also it will give you notifications of my classes. When you have the notification, you get motivated to attend. So that is kind of motivation for you also. So do follow the profile, hit a like. Thank you so much for watching, and you all have a good night.